Guys, welcome back to Medical Coding with Blue. We all know what today is. It is the original Q&A Tuesday. So, before we start off with all the questions, I want to talk about the Z48.1 code that we talked about yesterday. So, as it turns out, that encounter for planned post-procedural wound closure that we were talking about for the suture removals, you cannot put that with the surgical dressing change, the Z48.01. You can't put them two together. What I have been able to surmise from this section of the book, the Z48 section of the book, is that if the patient is having a suture removals and dressing changes done in the same visit, you would only report the Z48.1. Now, if the patient comes back later and they're having a surgical dressing change, that's it, it would be the Z48.01. Now, if the patient is coming in and this is not related to a trauma, because remember, you cannot use those Z codes in conjunction with the traumas, okay? And it is not related to a surgery, then you would use a Z48.02, which is encounter for suture removals, okay? So it's just something to keep in mind. And it's a perfect example of still learning. Still learning after all these years. I'm still learning. So, but yes, I just wanted to clear that up. That was my bad. And like I said, I updated the key on Answer Monday, but I just wanted to bring that up. So, if they are having surgical dressing change and suture removals done in the same visit, you would only report the Z48.1. All right. So, moving right along. Let's start with the questions. Okay, so do you assign a diagnosis code during the aftercare period? I'm assuming that what this means is like if the patient came in for appendicitis and then they had surgery and now they're in the aftercare. No, you would not code the appendicitis because hopefully the surgery took care of the appendicitis, right? Then you would only report the aftercare for the digestive system, okay? So if the surgery takes care of the condition, then no, you don't continue to pick up the condition. All right? So next question. Does code 99024 apply to the aftercare visits and the follow-up visits when the patient is no longer has a condition? The only time you're reporting 99024 is when the patient is in their post-op global period, whether it's 10 days or whether it is 90 days. That CPT code is essentially telling the payer or the person who's doing statistics that this patient is in the post-op global period. Okay? Now, the only time that when they're out of the global period, okay, and they're out of that 90-day global period or they're out of the 10-day global period, you would use a regular evaluation and management code, regular E&M code, when you're doing the follow-up, when they're outside of the global period. Okay? Does that make sense? So, but yeah, I mean, that takes care of that. So remember, 99024 is only when they are in the global period. And yes, while they feel better, and like the patient with appendicitis, right? And it's a couple months down the road, and oh yes, I feel better, and I'm well. You would still continue to report that 99024 until they are out of the global period. Okay, so it doesn't matter if they're healed. If they are in that global period, you stay with that 99024. All right, next question. If the billers ask for other codes besides Z codes, is there a problem with certain insurance companies? I guess accepting like certain codes. Okay, so here's the issue. One of two things is probably going on. Either the documentation is not supporting the codes that were selected, or the incorrect codes were being selected. Okay, now if neither of these is the case, and the documentation supports the use of those codes, and everything is there like it's supposed to be, everything's documented, then the billers, because the majority of them are not certified medical coders. Now, I'm not saying not all of them are. I'm just saying the vast majority of billers are not certified medical coders, okay? There is a difference there. If somebody has a certificate that says, yes, I am certified biller, okay, that is not the same as somebody that has a CCA, a CCS, a CCSP, a CPC, a CPCI, it's not the same, okay? We have credentials, we have those credentials after our name. And billers are trained to do billing. They process paperwork, they deal with the insurance companies and things like that. Their function is extremely important. And the thing is, with coders and billers, it's important that if the biller is sending this information back to you and saying, well, this is incorrect, okay, if it is correct, explain to the biller why it is correct, okay? Make sure you use your resources. Make sure you cite where you're getting this information from. So this way that they can understand, all right? And something else I wanted to bring up about that. Oh, yes. I did have a instance where I did get stuff kicked back from the billing side of the house. And it was that they wanted me to pick up an uncertain diagnosis. And I cannot do that. In the outpatient setting, we only pick up diagnoses that are definitive. What is the most definitive? If we do not have a definitive diagnosis, we have to go with the symptoms. I will not pick up something that is probable, likely, maybe suspected. If that is the way that is documented in the documentation, on the outpatient side, we don't pick that up, okay? So I had to make sure that I wrote everything down so that it could be resubmitted back to the biller so that the biller can understand what my reasoning was for selecting what I selected, okay? So I do get that. They have kicked that back before, and every time I've been able to show them, okay, this is why, this is what I was thinking, this was my thought process in that, okay? So that may be the case in that case if they're kicking stuff back. So be sure to just look at the documentation again. Make sure those codes were selected correctly. See if it's something in the documentation. Is there something that's missing? Those things. So that way you can see. But if all else fails, talk with the biller and try to get to understand what their thought process was too, as well. Okay. It's all about communication. All right. So, does your compliance manager get involved when your providers don't want to comply? So I've been waiting to answer this question. Here's the thing. Admittedly, I am territorial when it comes to my providers. You ask any of them and they will say, oh yes, she is territorial. Now, why am I territorial? Because I never want to get my providers into the habit of saying, well, I don't like what she's saying. I'm going to go to somebody else and ask them and see what they think. And I'm going to go, and do, no. At the end of the day, I am the coder. It is my responsibility to make sure that they are getting full credit for everything that they're doing. Okay? If I query them, if I ask them to do something and they don't want to do it, that's on them. But they will not go to other people and try to get, oh, well, I don't like her answer. Let me go find another answer that I like. No, that's not fair. It's not right. And this is why I always have my resources every time I come to them, because you can't just say, do what I say, and that's it. No, you have to explain why. This is why I try so hard to have a good relationship with all of my providers. Because, and it's not always going to happen. Sometimes you have personalities that conflict, and there's just sometimes that when it just does not work out, because maybe one or two, both parties just cannot get along, and that's okay as long as you remain professional. You never want to lose your temper with a provider. You never want to get into a situation where things get ugly. You don't want that, and thankfully I have avoided that. So but at the same time, I understand that not everybody is going to understand things maybe the way that I say them. So maybe giving them to somebody else, they can work better with that other person. So, I mean, it all depends. But the only time that I have called in my boss is when like literally nothing that I said was coming across at all. I had my resources. I showed where I had gotten it, and it was just, and the provider just did not want to. I mean, just literally refused. So my boss did have to step in on that instance. And sometimes it happens. It's not. I don't know. I mean, like I said, not all times it's going to be really easy. Okay, some things you have to work with. Okay, and the one provider that I did have, that he insisted he was not going to do what I told him to do, and I said okay. So I was just patient with him the whole time, and I just let him say, I'm not doing it. I'm not. I'm okay. You don't have to, And he's like, whoa, And I think it took him off guard when I said, okay, you don't have to. If you don't want to do it, then don't. I mean, I can't force you. All I can do is just show you that, this is the reason I'm selecting this, and this is the reason that you're getting a lower level, because, you're not documenting, you're not telling me what's going on. Well, I spent all this time. I understand, but where is it in your documentation? It's not here, So, and after a while he was like, okay. And so now he's like, all right, well, I'll work with you. And he works with me now. And he's one of my better code selectors now. So he doesn't select unspecified diagnoses when he has a laterality documented anymore. So I'm very proud of him for that. But like I said, just try your best to have good relationships with your providers. If you let somebody else be a mouthpiece for you, the way that they look at things and the way they interpret things may be different from the way that you do. And the best person to talk to providers is a person that's actually coding their stuff, which is the coder. Okay. So just keep that in mind. I mean, like I said, it is so valuable to have good relationships with your providers. And, Dr. X got to think again, because, if he hadn't gotten the ball rolling, I mean, I'm pretty sure I would have, but I eventually been communicating with my providers. But like I said, I was scared in the beginning, and I didn't know if providers wanted to talk to me, But if you can develop a really good relationship with your providers, and not just by email, especially if you are in a clinic or maybe in a hospital, and if maybe they work in a different area, just make sure that you go over there, give them some FaceTime, like say, hey, how are you? You're not just a voice on email, you're an actual real person. Because once they get to know you, it's sort of hard for them to not listen to your emails or not answer queries, because if they know the person, then they have a face with the name. So, just another tip from me to you. All right, so next question. Do you buy new Coder Desk reference books every year? I'm trying to sneeze. Okay, it's gone. Coder Desk reference. I buy them every other year. I do try to get my hands on a book every year, but a lot of times the areas that I need, thankfully, they do have some updates, but not so much that it's impactful when I'm looking for a code, so, but yeah, usually every other year I'll buy a new Coder Desk reference. So, all right, so next question. How many coders are usually in a doctor's office compared to hospitals? It depends on the size of the doctor's office. It depends on the size of the hospital. I've been in hospitals before where there was like maybe 15 coders in the department, or, because it was a specialty hospital, so it was like 15 coders. It was very small. I've been in areas where it was 50 coders, and I've been in areas where there was like 35 coders. So, they're just kind of scattered all over the hospital. But I haven't really worked in doctor's offices, like one-on-one doctor. I have not done that yet. So, it just depends on the size of the facility, And the last question, are coders required to do a certain amount of charts or codes a day? So the way that it works in my facility is we go on averages. So the average, because not every day you're going to be able to hit your quota. Okay, so if your quota is 90 a day, or if it's 120 a day, 125 a day, you're not always going to be able to hit that, because you have classes, you have provider education, you have all kinds of things that you have to do that it's not related to coding. So in those instances, they usually take that time out, because you're not coding, you're doing other functions, whether it's that you're learning HIPAA or something. That's not dedicated coding time, so that time gets taken out as long as you're documenting it. And then they average, how many are you producing in an hour, how many are you, how many do you code per day, over a certain amount of time. But if you are meeting quota, like if you're, say for example, your quota is like 100 a day. Okay, let's just throw that out there, 100 a day, and you work an 8-hour day. Okay, so you're working this 8-hour day, and you're supposed to do 100, and you take off an hour because you are having to do education. Okay, and let's say instead of doing 100, you did 90. You still, average per hour, you still passed for the day, because 1 hour of that you weren't working. So just, that's just the way it is. But yeah, it's not hard and fast. At least that's the facility that I work in. It's not hard and fast like that. And I can't imagine any place that would have that you have to do a certain amount per day. It's usually based off averages. And sometimes you're going to have instances where you have really hard charts, particularly if you're working in like a level 1 trauma center, or like maybe a hard specialty or something. Sometimes records take a little bit longer to get through. Encounters take a lot longer to get through, and you're just sort of having to read a lot of stuff that's going on, and you're having to work the encounter. So when you have those, and then you have days where you have really, really easy stuff, and then you're able to pump out a lot of encounters in a day, that sort of makes up for the time that it offsets, right? The times that you had slow days, and then the times that you had, really good days. I have days where I do 150 encounters, and then I have days where I'm doing 80. And I'm like, ooh, and it really bothers me. I hate that, because I try to reach a certain amount every day, and if I don't reach it, then it bothers me. But then sometimes I just have to tell myself to relax, because I do work very hard to get education done, and to make sure that I do slideshows for classes and things like that. So there's a lot of things that I do, and I've talked in other videos about how I have an open door policy, and most times my office is jumping. Today I closed the door, though. I kept closing the door. The door was closed because I was really trying to finish these slideshows that I had to do, because in August, I have my 2 classes that I want to do, and I need to get this in, and so finally I finished it today. So the slideshow is going to be able to cover both classes, so I'm really happy about that. My supervisor has to approve the slides first, and she has to just double check it and make sure everything is there, and that's fine. So, and a lot of times it's just like, she just tells me, hey, change the font or change the size. Okay. Because the information is sound, so that's about it. So that closes out Q&A Tuesday today. So I hope I answered all of y'all's questions. One other bit of housekeeping. If I don't respond to you right away, I am very good at responding, as you may all have noticed. I don't have like a long lag of response time, because most of the time my phone is with me. However, in my building where I work, I don't get signal very well sometimes. Sometimes I do, and sometimes like my phone's like bleep bleep bleep, bleep bleep bleep, and then sometimes it will not make a sound until after I leave work. And I am not one to be on my phone all day. If I check my phone, it's during a break or during lunch. I am not on the phone during work time, because that's one of my pet peeves. I mean, like, I don't know how teachers do it. When they have kids out there on the phone, you know what I mean? They're trying to teach a class. That would drive me nuts. And so I don't like that. Even I've had coworkers that they're on their phone, and it's just like, really, can you not be on your phone? I hate that. I think the only ones around me that should be on their phones is probably the doctors, because they're waiting on a page or whatever. But that's just me. And like I said, my phone is always in my purse. You don't catch me on my phone. And like I said, the only time I hear it going off is if I get a signal, and even then I'm not running to get my phone either. Pretty much my phone is in my purse. Which is not on my desk. So, and then sometimes I get so wrapped up with what I'm doing that I don't even look at my phone till the end of the day. So if I don't respond to you right away in the morning time, that is why. So if you do get a response, then it's just your lucky day. But yes, I will get back to you. I've been really good about that. So yeah. Anyway, so I have another exciting show planned for tomorrow, but I'm not going to talk about it because I'm going to bring it up tomorrow. So anyway, if you have any more questions, please let me know. I am always working on the following week original Q&A Tuesday episode. So just let me know. Put the questions down in the description box. Put the questions down in the comments, or shoot me an email, and I will include my email address down in the description box. That's what I meant to say. And just let me know. All right. So I will see y'all on the next episode. So if you are a medical coder, a medical coding student, somebody curious about the fascinating world of medical coding, a provider or a nurse, I invite you to like and subscribe to my channel and follow me on my journey in medical coding. All right, well, y'all have a great evening, and I'll see y'all tomorrow. Bye.